So it's 8 o'clock and let's try to get things started on time so that we have some time at the end for discussion. I'm Swapnil Hiramat. I'm doing the introduction today on behalf of our division head, Pierre Brown. We are fortunate today to have Professor Daniel Coyne from Wash University, St. Louis, speak to us about a topic that I'm sure is close to his heart and it's really important for all of us. So Professor Coyne, who is, at Central Time, so has woken up early for us to give this presentation. He's a professor of medicine at the Wash University, St. Louis. He's the director of the Hemodialysis Center and the Center for Medicine there as well. He has, a long research career spanning many aspects of chronic kidney disease, but in particular, especially anemia and bone disease. He did the DRIVE trial, which really set up the stage for using iron more effectively, as well as he's been a PI for some of the HIF trials. In particular, for me, of course, he was a giant slayer when a few years ago he reanalyzed the data from the Amgen-led normal hematocrit trial, which actually changed practice for many of us. So today we are fortunate to have him speak on HIF-PHI inhibitors for the treatment of anemia and CKD. This session is of course being recorded and it will be available on YouTube later on the Ottawa Renal channel. And we are grateful of course to funding from AstraZeneca to make this possible. So without much ado, go ahead, Dan.
Thank you. Let me start with my conflicts. I'm a consultant to all the major companies that are trying to get HIF-PHIs on the market in the United States. I have some other conflicts that I don't think apply. I'll have a disclaimer that I'm not a statistician, but I have participated and led several trials. And at one point I did sleep at a Holiday Inn and I freely steal opinions from a lot of smarter people and I never give them credit, by the way. I've also read the FDA and Fibrogen briefing books on roxadustat a few times, which is more than most people probably can say. Let's talk about HIF-2 alpha. So HIF-2 alpha is in hypoxia responsive cells. It's constantly formed and degraded after being marked by PHD enzyme and PHD2 specifically. And then something happens. Let's say you get anemic suddenly. The PHD activity falls dramatically. HIF-2 alpha is stabilized and in conjunction with other proteins turns on a number of genes, including EPO, a number of iron transport genes in the GI tract, and transferrin. And so the net effect is better erythropoiesis. The drugs we're talking about are small molecules that block PHD2, but they differ also in their half-life, and that means how long they activate genes and perhaps the genes that they activate. In addition, they have variable effects on different PHDs, which can interact with HIF-2 alpha, but also interact with HIF-1 alpha. So these are not drugs that you can say are acting identically. They will vary in their potency, as you'll see, and it may well be that this affects some of their safety profile in addition. First, let's talk about efficacy, and mostly that means increasing the hemoglobin and reducing salvage therapy, mostly transfusions, but also IV iron or ESA requirements. This is anarodustat approved in Japan for treatment of CKD-related anemia, and this is a classic dose-finding study. So you give populations of patients either 2, 4, or 6 milligrams a day of anarodustat, and you can show a dose-dependent increase in the hemoglobin, and then you can maintain the hemoglobin with further dosage adjustments. And it's actually pretty easy to titrate patients on these to a hemoglobin target and maintain them there. Arguably, you may maintain a few more in target than ESAs, depending on the product you're using and how often you're administering the drug. Lastly, when you stop these drugs, the effect goes away pretty quickly. They'll have a steady decline in their hemoglobin back to the previous levels. And that becomes important too for safety issues. That was in CKD patients. This is in dialysis patients. So we've got roxadustat now. And this in the ESA naive patients, you've got a correction study and titrating to goal. Here's a conversion study, take people on ESA at goal, convert them over, and maintain them for really as long as you want. We now have data going out 3+ years with these drugs showing you can easily maintain people at hemoglobin goal for extended periods of time. So I think these agents clearly raise and maintain hemoglobin comparable to ESAs. It's arguable whether or not they're better than ESAs, and I'll get into a little bit about ESA hyporesponsiveness in a minute. And like ESAs, their ability to reduce transfusions largely depends on whether you can achieve and maintain the hemoglobin and the stage of CKD. Transfusions are relatively unusual in the CKD ND population and common in the dialysis population. So consequently, the benefit of these in transfusion reduction is expensive in the ND population because you need about 10 patients to get to goal. But there are differences in how they've been dosed, and maybe that reflects a potency difference. I mean, it depends on whether you're an optimist or a pessimist, I suppose. So if we look at the vadadustat dialysis-dependent data, and this is in patients who have a correction of anemia, and this is a maintenance of anemia or conversion over. And you can see that vadadustat in blue corrects much slower than the comparator, which is darbepoetin in this study. And the same thing occurs in the conversion study. In contrast, roxadustat, and this is from their ND population, but you can see the same thing in their dialysis population. They tend to overshoot initially and then titrate down to their goal. They may have thought that was a smart idea. In retrospect, I think they kind of regret it. The FDA did point out that in every single one of their NDD trials, they did this. They overshot and then brought the hemoglobin back down to goal. And that could have impacts on various things, including thrombotic rates. But regardless, if you look at the NDD data from over 4,000 patients with roxadustat, the placebo-adjusted change in hemoglobin is 1.72. And there are no substantive differences based on GFR. In fact, this is just driven by that these people have higher hemoglobins to begin with, and that's why they didn't go as high. So with that type of efficacy, it's not surprising that you can reduce any rescue therapy, which is transfusion, IV iron, or the need for ESA dramatically. And the hazard ratio in the combined trials was 0.19 for roxa, reducing any therapy. And for transfusions alone, it was 0.26. The absolute difference is 10%, which gets back to that you would need to treat 10 people for a year in order to prevent one person from getting a transfusion. That gets expensive. Hifs are also reportedly effective when the iron stores are still low, unlike ESAs, which have require bigger EPO doses, or you don't get them to goal if they're iron depleted. So this is again an analysis of data by Provenzano in the iron replete patients. These are CKD. I don't even remember. This is a CKD ND population. The hemoglobin goes up 1.94 in the iron replete. It goes up 1.94 in the iron deplete, which were defined as TSATs less than 20% or a ferritin under 100 or both of them. And unlike the ESA data, you don't need a bigger dose to get the iron deplete there. Now, this is attributed to better iron absorption because of that increase in iron transporters and increase in transferrin levels. Other putative benefits of HIF-PHIs, at least some of them, and there does seem to be variability for this one, reduction in Ldl cholesterol. This is looking at roxadustat. Other ones don't seem to do this quite as much, and so that could be an off-target effect. Reduction in IV iron use, and this is highly dependent on the design of the trial, and we'll talk about this in a minute, and increased serum iron. And with one exception I found, they all seem to do this pretty reliably. They are enhancing iron absorption from the gut to a certain extent, and or release from the RES system, causing a higher serum iron, which most of the time you won't detect if you're looking at TSATs because the transferrin goes up also. And so iron over total iron binding capacity, which is largely transferrin, that doesn't change. But in fact, the serum iron is higher, and that probably does contribute to its erythropoietic effect. Now, it's claimed, and there is at least one other publication I won't cover, that there's an IV sparing effect. I pulled this from Fibrogen's FDA book, and I want to be a little skeptical on this one. So are HIF-PHIs really iron sparing? And they presented this figure, which I've altered just a little bit by covering some stuff up. And they said, well, their goal was to look at iron use, IV iron use, in this window from 24 to 52 weeks. And in that period, there is significantly less iron use in the roxadustat arm than the EPO arm, and the reduction is about 25%. So you could say that's an added benefit of those. Although I think skeptics would say, well, where did they start? And surprisingly, randomized trial, tons of patients, and they started wildly different. So I think while there are changes in serum iron, it remains to be seen in a routine basis whether these actually lead to reductions in IV iron use. Another claim is that HIF-PHIs work better than ESAs in inflamed patients, usually defined as those who have a high CRP. And there's two ways to prove that. One, there's no dose drug increase at people with higher CRPs. Or second, that you achieve a higher hemoglobin at higher CRPs, unlike with ESAs. So in the same briefing book, they also presented this data and made this claim also. And so here we see the roxadustat hemoglobins by CRPs broken into quintiles and the EPO alpha hemoglobins. Now, frankly, this hemoglobin is as good as this hemoglobin. So you don't really see it there, but they're kind of making this argument. I think to be critical, this is just a dosing algorithm issue, that in these trials, Roxa was targeting somewhat higher hemoglobin, or at least the dose adjustments led to routinely higher hemoglobin, especially in the first year, as we saw from some of those curves, although this is a dialysis population I'm showing right now. And then second, well, if you look at doses, that there is this steady increase in need. I'm not certain it's really all that steady. And Roxa doesn't have an increase, and therefore this supports the initial claim. Alternatively, maybe it's that HIF-PHIs require higher doses at the low CRP levels, that there's something about these agents that if there's not any inflammation going on, you just need to give more of the drug. And secondly, is there really a difference here in these curves? If you compare the second quartile to the fifth quartile, Roxa requires actually a 10% dose increase, and ESAs are requiring only a 15%. I think there's truth in both of these arguments that I'm making here. I would say, to finish on efficacy, because most of this is about safety, that they do increase hemoglobin in a dose-dependent manner. There seems to be some potency, although that could just be dosing algorithm issues. And their efficacy is at the best similar and maybe superior in select patients, but I don't think that's been proven. If you correct flaws in phase 3 dosing, though, we may actually influence safety outcomes. And this, I think, becomes a big issue for approval, at least in the US. Most PHIs do increase serum iron. They rarely raise TSAT because they're also raising transferrin. Maybe they are iron sparing, but it's difficult to show this on a routine basis. And I know for a daprodustat study, we have a poster where it did not have an iron sparing effect. The ability of HIF-PHIs to better manage anemia in hyporesponders, I think it needs to be more convincingly demonstrated. And you can't do that over a year. It's about a 6-month trial at best. Now let's move to HIF-PHIs, where I think this quote from Mark Twain applies to all parties involved. And hopefully you'll see what I mean. So let's start with roxadustat. So roxadustat in the non-dialysis population, they did 3 major trials involving over 4,000 patients against placebo. And they stated that the FDA wanted them to do placebo-controlled trials. And there's arguments back and forth between the two of them about what they really agreed to. The first point of this was that there was bigger dropout in the placebo arm of this trial. And in fact, at 1 year, 71% of the Roxa patients were still on assigned drug versus only about 53%. This has a huge implication, but what has the bigger implication is that these patients would continue on their assigned drug unless they or the doctor dropped them out after they started dialysis. So this was not only a non-dialysis study, it becomes a dialysis study, at least incident dialysis study. So imagine a Roxa patient starts on hemodialysis. Their hemoglobin's probably going to be at goal. They're going to stay on Doxa a lot longer than Roxa, a lot longer than a placebo patient who starts low and is probably going to be starting on ESA right off the bat. Okay. Despite all of that, the primary endpoint was on study, not on drug, and it was for MACE. This analysis has the advantage that at the randomization point, there were 56% of the patients on Roxa, and even at 30 months, that rate really didn't change very much. So you're looking at similar proportions, and you get a hazard ratio that's above 1, but the confidence intervals clearly cross 1. Some may object to this number here. If you then censor at dialysis, which was another proposed endpoint, and I think makes a lot of sense, first because it maintains the ratio of patients, and that actually comes out to be 1. And so by this, roxadustat looks safe in our usual analyses. That has been criticized in a publication by Wolfgang Winkelmeyer, who said that they should not have used a non-inferiority framework, as it is demonstrating the drug is not unacceptably worse, and went on to say that the FDA guidance called for active comparison for non-inferior trials, and that they should not have used all-cause mortality, as many deaths are not along the causal pathway. Interestingly, the FDA actually does the exact opposite. And then he criticizes the intent to treat analysis. And I have no idea what the hell that's all about. I mean, we always use intent to treat for these. I'm not certain what he was getting at there. And then he says, oh, wait, the FDA agreed to all of this anyway. I think the problem with this is this. We are not expecting HIF-PHIs to be superior to placebo based on safety. Nobody realistically thinks that. I think that the data that raising hemoglobin saves lives has long ago been killed by all but some zealots. And really, what we're expecting is superior to placebo for anemia correction. And indeed, it was clearly superior. What we want in safety, if you really want superior safety, then you should pull ESAs off the market immediately. And nobody wants to do that because we do need these drugs in individual patients. So if you look at the Roxa versus placebo non-dialysis pool, the primary endpoint yielded this hazard ratio and confidence intervals. You can do secondary endpoints, and several were proposed, including just getting rid of low GFR patients, because there were a huge number of patients who had GFRs less than 10, and by any standard should have started on dialysis immediately. You can just censor everybody at dialysis and say, okay, we're going to make this truly a non-dialysis study by doing that. And you wind up with neutral results. You can just look at the US patients and find out a neutral result. Or you can do this. On treatment, on your assigned treatment, plus 7 days. And only in this do you get a significantly higher hazard ratio. but you also eliminate more than half of the events that you're looking at. And that's the one the FDA decided they thought was very important and needed to be looked at as a sensitivity analysis. So this is the Kaplan-Meier curve for that, hazard ratio 1.38. They admit that the on-study analysis, which was predefined, shows no significant risk of MACE relative to placebo. They say this suggests increased risk, though, the OT plus 7 analysis. And then it says, well, this is complicated by differential exposure. To which I ask all the statisticians out there, well, what does exposure mean? And they're probably nodding and saying, oh, that foolish guy, it's obviously drug. But it's not just drug. It's actually exposure to dialysis. And this is a huge confounder, which should have killed this type of analysis for this drug, in my opinion. So let's go through the data to support that. The Roxa group was far more likely to remain on drug after starting dialysis. In fact, at 9 months after starting dialysis, 50% of the patients randomized onto Roxa were still on drug versus a little less than 30% in the placebo arm. And the effect of that is that the Roxa group is disproportionately enriched with dialysis patients as you go on. At 12 months, there are 10% more dialysis patients in the Roxa arm than in the placebo arm, and this becomes 20% at 24 months. But wait, it gets worse, because if you go back and ask who's left in the placebo group, it's being enriched with healthier and healthier patients. So if you look at the median baseline eGFR of the patients at any given point, the average GFR in this study was 17, far lower than any other anemia trial that we've done. And of course, they're the same in both groups because of the randomized nature of this. And at 24 months, the Roxa group, those people left, if you go back and ask what was their baseline eGFR, it's barely budged. It's still 17.5. Whereas the placebo arm now has patients with an average starting GFR of 22. These are remarkably healthier patients. And you're comparing apples to oranges when you do this type of analysis. And when does these curves separate? 12 to 24 months, when you're getting more and more separation in the proportion of patients on dialysis. And let's not kid ourselves. Dialysis kills patients. I mean, that's what I tell my fellows every year. I say, if you start someone on dialysis, you are increasing their risk of death. So you better think that they really need it when you do it. The rate in the US is almost 2.5-fold higher than a stage 4 or 5 patient at month 2, and remains substantially higher throughout the first year, really. So if you know that dialysis dramatically increases cardiovascular events, and that there's this massive adjustment in the proportion of patients in the arm, I think a sensitivity analysis of treatment on treatment plus 7 is at the very best foolish, and at worst, I probably shouldn't say what it is. Another criticism was that the roxadustat studies had a lot of dropout, and it did have a lot of dropout with treatment completion, but that was the nature of a placebo-controlled trial in patients with very low GFRs. If you actually look at the people completing the trial, it was as good as in treat. So I don't think that that's fully true. Now let's turn to the FDA query system. And first I want to focus you on this paragraph, which talks about MedDRA. And the FDA said that they've developed a standard set of queries for new drugs. And these new queries, as well as ones developed over the years by the FDA, were used to look at adverse events in the Roxa program. And as part of this, they note that when they looked at sepsis in the MedDRA system, there were 81 patients who received Roxa, who had it with roxadustat. Whereas when they used their query system, they identified 132 patients who had that term somewhere in their report. The first question I have is, who's got this query system. Is this validated? I mean, just because you're finding the term sepsis in here doesn't mean they actually had sepsis. And what exactly is the FDA saying here? Are they saying that the FibroGen didn't properly query the investigators about adverse events? These studies were done by 3 major companies in different parts of the world, and I don't really know what they're getting at, and they don't make that accusation. And lastly, although they found 51 new patients and they say additional adverse events, they don't actually say additional sepsis events were found. So I'm not certain what this whole query system means. And I don't think it's clear when you read the reports how valid it really is. And I'll bring that out a little bit when we go through further things. But first, let's look at adjudicated causes of death. And this is using the on-treatment plus 28 days analysis. And so total deaths were higher in the roxadustat M, but they had much higher exposure in the trial, patient years in the trial, if you will. So the risk difference when you adjust per 100 patient years becomes 1.48. And if you look at relative risk, this is about a 30% or 1.3 higher. There's no particular events that jump out as driving this, however. Okay, but don't forget, these are dialysis patients now. We're enriching it with dialysis. In some respects, is this really surprising that you're having more deaths as you go into this? I'm not convinced that it really is. Secondly, they then move on to serious adverse events, and they use the on-treatment plus 7 window. And in their tables, if they put term after it, that means MedDRA. All others are FDA queries. And they begin by saying that any relative risk less than 1.3 is difficult to interpret because of the imbalance in how long patients were in the studies. And then they go on to say that thrombosis queries for MI and stroke were the largest of all these events that they looked at for serious adverse events. But if we go back and look at MI and stroke under thrombotic events here, neither of those actually has a relative risk increase of 1.3 or higher. And the absolute increase we're talking about is literally 1 in 1,000 patient years and 3 in 1,000 patient years. So I think reading much into that becomes problematic at best. And MI and stroke are known to be much higher in people who are on dialysis than in CKD-ND. And both increased thrombotic events and seizures are already in the FDA label for ESAs. So when we look at these thrombotic events, I think a case can be made that they're really demonstrating that these drugs really should have basically the same label that the ESAs do right now about increasing the risk of thrombotic events, seizures, etc., as we see in the FDA labels for ESAs. They also put in the text that they queried for pulmonary edema, anemia, angina, fatigue, hypotension, and dyspnea, and all of these favored roxadustat. And that they only mentioned these because there were more than 11 events, and therefore they thought they were worth being mentioned. Although interestingly, they mentioned these things, and there's less than 11 events of those in the entire trial. So it's an interesting method that they use in presenting the data. The bad stuff gets into the tables and the figures, and the better stuff or the countervailing stuff, if it gets in as text. And then there was the 610 study. So the 610 study was independent of those 3 placebo trials, and it was Roxa versus darbepoetin for 2 years. And this study randomized about 600 patients. There was a little imbalance because at first it started off as a 2-to-1 study, and then they decided they'd change it to 1-to-1. And the number of deaths were greater in the Roxa group in the on-treatment plus 28 days. But the difference was too small to be conclusive. there was a bigger difference if you looked on study between the two arms. And using the FDA proprietary system, they pulled out select adverse events from this study. And they focused on infections, bacterial infections, pneumonia, and thrombosis. Clearly, these were not all the things that they were looking at. I think these were the ones they wanted to draw our attention to. 3 of the 4 are above a risk ratio of 1.3. Some of these have very small numbers. In fact, most of them do. They then went on in this and said several other adverse events, not necessarily serious ones, were also found to have imbalances. And then they listed all those adverse events which disfavored roxadustat over darbepoetin, beginning with hyperphosphatemia. Well, this is actually kind of interesting to me, because if it's hyperphosphatemia and you're saying there's a relative risk of 2.3, show me the serum phosphate levels. If there's not a difference in the study between serum phosphates, this is a great indicator of what the bias of reporting is in an open label study where one of the drugs is standard of care and the other is an investigational agent that's given orally. They also call out other things like hypotension and other factors. But if we look at the text of the FDA, hypertension was actually higher in the ESA group by 4%. And developing end-stage renal disease was higher in the ESA group than roxadustat. And hyperkalemia was also significantly higher. So in some respects, I think this is an interesting analysis, but I'm not certain it has a lot of validity about the relative risks of the drug when you're doing these post hoc draws using query system. So I've come up with a new term. It clearly isn't p-hacking. They don't even bother with p-hacking. We'll just call this safety trawling. You find things that look bad, you make a big table that looks kind of impressive. Now, based on all of that, if you had to guess what the 610 study showed, I'm sure it would look bad. And indeed, it doesn't. I'm kidding. It actually looked good. So in this study, the on-study analysis, on-study just mean, the two arms randomized, had a hazard ratio of 0.89 favoring roxadustat. Obviously, the confidence intervals cross 1. On treatment plus 7 days looked even better. And whether you looked at MACE plus, or all-cause mortality, all of these insignificantly favored roxadustat, and none of them are concerning. So if I was looking at the Roxa NDD versus placebo data, I'd really just go back to this table, which is from the FDA analysis. And it's got the MACE data for all the studies, hazard ratio 1.1, as I showed you, and the 3 trials that are components of it. There's a little bit of variability, but it looks about right. MI seems to stick out more on the side against roxadustat. Stroke is a little more equivocal, but both of these are already in the ESA labels. And I would say what I would do is these results are actually pretty consistent with TREAT, which did not show a significant increase in MACE versus placebo. But they still would probably warrant a package insert that says may increase the risk of cardiovascular events, stroke, thrombotic events, and death, just like the ESA label. What the FDA looked at was their on treatment plus 7 analysis and said, we have serious concerns that this is actually more risky. And in fact, they said that it should not be approved. I want to point out one other thing about these tables, which are from the FDA report. They both say favor ESA, but these trials were all versus placebo. Is this a Freudian slip? Are they saying that they're favoring ESA in all of this? This is really bizarre that somebody could draw these reports, do all this effort, and then manage to mislabel the forest trees that come from everything, or the forest plots. Anyway, moving on. Maybe what they were actually concerned about is they wanted to shoehorn HIF-PHIs into a single group, and they were already aware of the vadadustat CKD NDD data, which had an active comparator, darbepoetin. Half of these trials, these were two different trials. One was a correction study, so the patients were ESA untreated prior to that, and the other study was ESA already, so this is a correction trial, if you will. They were randomized 1-to-1 to Vada or darbepoetin. Vada was given as a daily dose. And in the US, all the patients had a hemoglobin target of 10 to 11, consistent with the ESA package insert. Ex-US, it was 10 to 12. Vadadustat, again, corrects the hemoglobin a little bit slower than the darbepoetin drug. And same thing here. It kind of undershoots initially and then gets to the same thing. But when you looked at MACE from this, you get higher risk with vadadustat. The hazard ratio is 1.17. Confidence interval on the lower side does not cross 1. This is using age as a dichotomy at age 65. If you do a continuous variable for age, then this drops just a little bit, and this goes down to like 0.99 or 0.98. But that is a post hoc analysis. If you look at expanded MACE, the confidence intervals still get pretty high, but they do cross 1. Okay, so there's clearly a signal here of harm. In a pre-specified subgroup analysis, they looked at the US patients versus the non-US, and it wasn't the US patients who were getting into trouble. It was the non-US patients that were driving this increased hazard ratio. And remember, they had the higher target. I think the take-home message is don't target people to above 11, and that most of the world is crazy by saying we should target 10 to 12. Let's turn now to Hifs in CKD dialysis-dependent population. And we'll stick with vadadustat. This is published in the New England Journal a while ago. So the vadadustat safety data, 2 different pooled trials, overwhelmingly prevalent patients, less than 10% were incident dialysis patients. And here, the hazard ratios are fine, and the confidence intervals are fine. Vadadustat does not increase the risk of either MACE or expanded MACE in their analyses. And the subgroup who who were incident dialysis patients, they had essentially the same outcomes. And for cardiovascular causes, Dr. Winkelmeyer will be happy to know that the hazard ratio is 0.96 for that too. So all of this data supports that at least on MACE, vadadustat looks safe. It does have the problem that it corrected the hemoglobin pretty darn slow, and compared to the darbepoetin corrector. So there's more of an efficacy issue in the dialysis population for vadadustat, which is probably largely what they were doing with their protocol on dose adjustments. Vadadustat is awaiting FDA review of its approval. It's submitted its NDA for both populations. They submitted it. And hopefully vadadustat will take some of these FDA query outcomes that we were seeing with Roxa and present some of that data so we can see if there's reverberations of those thrombosis and stroke signals coming out of the VADA data, especially in the non-dialysis population. Now, the FDA wanted nothing to do with roxadustat's analysis of incident patients, even though there were 1,500 patients in that in those trial analyses. They wanted to look at all dialysis patients lumped together, regardless of incident versus prevalent. And for that, there were 3 trials with almost 3,900 patients. At the completion of the trial, 58% of the Roxa group were still on assigned drug versus 66% of the EPO group. That's probably to be expected given these were open label trials, and EPO is the standard of care. So there's about a 12% difference in drug exposure as we go through this trial. The primary analysis was supposed to be on treatment plus 7 days, and that leads a hazard ratio of 1.02 for MACE. Confidence intervals bracket 1. All-cause mortality and CV mortality, essentially 1 for these. If you look at MACE plus, it actually favored roxadustat, although it was insignificant, and that's because heart failure and unstable angina seem to be somewhat less for that. The FDA, in their analysis, focused on study, which they called a sensitivity analysis. And they talked about this a lot, emphasizing that in this analysis, the hazard ratio is 1.14, and the confidence intervals does not cross 1, barely, but it doesn't. So in their interpretation, the FDA's, the on-treatment but 7 analysis showed no significant risk, but the on-study does suggest risk of MACE relative to ESA. But they admit, and this is their wording, that this risk is regardless of drug discontinuation or use of alternative therapy. Now, what could be an alternative therapy if you were in the Roxa arm and you stopped it? It's ESA. So imagine a patient on study analysis who gets randomized to ESA. They drop out at 18 months. They get ESA the next 18 months. All the risk during that 36 months of MACE is attributed to ESA. But in Roxa, they drop out at 18 months. They get ESA the next 18 months, and all the MACE risk is attributed back to the Roxa. This is not a trivial matter. At 40 weeks, a quarter of the Roxa patients were off the roxadustat, and many of them, we're never told how many, were probably getting ESA. And at 90 weeks, this rate was up to 50%. So despite all that, the total deaths, if we look at adjudicated deaths, was 14.5 versus 15.1. Adjusting for the patient years, this becomes 8.1 versus 7.6, a difference of 6 deaths per 1,000 patient years, which in the FDA graphic becomes this big blue bar with the number 1.08 written on it, meaning an 8% increase in relative risk. And then when you look at the events driving this, this has a big relative risk marker, but the absolute risk is 3 per 1,000 deaths. And I don't really think you can make much of these numbers when you're talking about these tiny actual absolute risk differences. They then go through an analysis looking at serious adverse events, focusing on thrombotic events. And here I think they really do have another point about thromboses. There were absolute risk change was 1.9. The relative risk was 1.4 for all of these, although some of these numbers are getting pretty small. These mean nothing down here, and I'm not certain why they put them in. And these are known drug adverse reactions for ESAs, so that's why they show them. There's not a lot to make of this. This jumps out, but it's literally 5 versus 2 patients with peripheral edema. Who cares? So I don't really think we make much of that. And one of the problems I had going through the FDA presentation was the perception of overt bias against the roxadustat data and the way they showed it. And this is an important and yet I think an illustrative table. So this looks at important risks in the dialysis dependent population. And first they take a look at all the trials using MACE, on trial plus 7, on study, serious adverse events, and then the 613 study, that separate study I showed, or I will show you. And they all of these relative risks are actually, 0.07 higher, 0.14 higher, 0.02. This was actually lower. And yet they've got all these big red bars here. But really what you should look at is these blue bars. And that really comes out only when we're looking at thrombosis. And the risk differences here become larger. And maybe this is reaching a relative risk that's significant. So, if you were really fair, I think you'd draw this table like this. You get rid of the stupid numbers and you just have bars going. And when you look at this, roxadustat doesn't really look any different than the ESA comparator, in my opinion. But there is some question of a signal about higher thrombotic rates, which are not really even captured by the relative risks that you're looking at. And I don't even think the FDA needed to do that, because they did this, which is more important. They looked at time to first thrombotic event using all events and serious events in the 3 trials and on treatment +7, not a bias of on study. And roxadustat does cause a separation in these event curves and raises the issue whether there's some increase in thrombotic event. Frankly, that should be addressed by something in the label, because the MACE results from these are 1.02. And here's the curve. And, to take this and say we're not going to approve the drug despite this, I don't think is a fair assessment of the use of it. And the reason they may be removed in that direction was this trial. The 613 trial. Here's a tip: never use the number 13 when you name a trial. It's bad luck. So about 800 patients. This is not part of the safety analysis. It was intended to show some data about its comparison to Darby alone. And in the on-study analysis, there was about a 19-death difference in rate. And this is looking at all-cause mortality. And here are the 2 curves. Now, I will just say, the stranger one of these curves, given these are all prevalent patients, is the ESA curve, which suddenly stops having people die for about 10 months, and then starts going up again. But regardless, there is a separation in these deaths. And when you look at MACE from this trial alone, it's 1.43. It does cross 1, but there's only 800 patients in this. Non-fatal MI and stroke are not the drivers. It's just all-cause mortality. Now, interestingly, if you took MACE from this trial and threw it into the full analysis, you'd still come up with a hazard ratio for this drug versus ESA of 1.08. And the confidence interval, no, it does not cross 1.25 or 1.3 at the 95% limit. The FDA said they were not going to do that. And in fact, this came from the Fibrogen page submitted. So the FDA in August rejected roxadustat for use in both the non-dialysis and dialysis population. This data has been analyzed at multiple places around the world, and roxadustat has been approved for use in both populations in multiple countries. Dapro, Anaro, and vadadustat is actually approved for use in the US, or in Japan rather. So next week at the ASN, Dapro presents its phase 3 data. If the MACE is higher in NDD, the question will become, are HIF-PHIs dead for the NDD population, at least at the FDA? The DD data, I don't know what's going to happen to VADA, and it's harder to predict what the MACE outcomes will lead to at the FDA related to that. I'm hopeful that we get some data from VADA on thromboses and strokes and their analyses out of that. So in summary, all HIFs are efficacious for treating CKD-related anemia. I don't think they're identical in action, and this may actually have implications for safety profiles. Raising the hemoglobin with HIFs increases thrombotic events, so does ESAs, but maybe this is more than ESAs, and I don't think, given the trial designs, we can answer that. A pro tip, never go above 11 on the hemoglobin. Compared to placebos, they may increase the risk of cardiovascular events and death, and they warrant, I think, an ESA-like label, regardless of the trial results that have been generated to date. And maybe because of that. They've been approved in multiple countries, but not the US. And lastly, I'll let you read this while we discuss things. And this is actually a transcript, an edited transcript from an interview of a professor of surgery and health policy at Johns Hopkins discussing the FDA as it relates to Merck's oral drug, which reduced mortality rate by 50% when given for COVID. I think it's interesting to see the perception of the FDA that's out there right now, and I don't think this is a good perception for a regulatory body to have. Well, I hope that was controversial enough for all of you. Please feel free to ask me any questions or contest everything I said, because I know a lot of things I skipped over, and you may disagree on everything, and that's fine by me.
Thank you, Dan. That was wonderful. It was such a deep dive, especially into the FDA data. So while others put their hands up, if I could ask one question, is
Sure.
that they're probably worse than placebo in the non-dialysis, but like you say, they're similar to ESA, and in the dialysis population, they're similar to ESAs. So we have drugs which are effective. Why should we want new drugs? We have EPO and darbepoetin.
You know, I see, that's kind of like a grandfather bias. Well, we already have a drug that can do that, but I don't know what else these drugs can do, and I don't know the long-term implications for other outcomes. So I think keeping a drug off because they haven't proven they're better than a drug on the market is a capitalist bias. Darn you, you shouldn't do that. We should want different drugs on the market if they're accomplishing the major action and have comparable safety profiles. One, it drives down cost of drugs, but two, we may find out that these drugs have long-term beneficial effects. I didn't even have time to get into some of the data on that because it's all exploratory and it just takes years to kind of get to that.
Thank you. Dr. Noor?
Thank you, Dr. for the presentation. Seems like the data or the analysis were a lot of sort of structured post-hoc analysis, and was that due to perhaps poor study design? And would you suggest anything different if they were to start this program over?
Well, you know, I think there's probably two sides to that story, because the FibroGen has said that the FDA wanted this, and then the FDA said, well, we never agreed to a hazard ratio on the upper limit of 1.3. We said we'd take a look at the data and look at the whole safety issue. I think it's asking a lot to say, well, you just need to go back to the drawing board and redesign all these studies. And then bring us back another, you know, after $200 or $400 million, bring us back another 4,000 patients. We'll take a look at it. I think the bad part of the initial design was the differential change, the group changes as they got onto dialysis. I think two things should have been done. One, ban people with low GFRs from getting into this. Nobody with a GFR below 10 probably should have gotten in, maybe 12, because you had people literally with GFRs of 5, 6, 7 getting in the study. But the standard of care in most of the world is those people should have been on dialysis already. So there was no banning that. And number two, maybe censor everyone at initiation of dialysis. You would have to do a bigger study, more patients probably, of doing that. But that's the question we really have. In the non-dialysis patients, what is the safety versus placebo? And I think that the data we see coming out of the Roxa data is you look good. You actually, the hazard ratio was 1 for MACE when you censored at dialysis. So maybe they have to do that. I think the FDA is going to want a study versus ESA, a bigger one. Who knows what they want? Any other questions?
So any predictions for next week?
Well, I think it'll be another controversial week. What can I say? I don't know. I don't want to, we'll see. We'll see. I kind of had my predictions at the bottom there. I think a lot of it will depend on what daprodustat looks like in the non-dialysis population, and we'll see what happens there. What do others think of how the FDA did this kind of query system, kind of, I called it data safety trawling, but I mean, I'm not certain when you go looking for things like this, if you're really finding truth or just differences.
May I have a comment on that or question?
Sure.
Thank you for that. I don't understand or know all regulatory bodies, but the thing that always impressed me about the FDA is that they analyze the data so in detail and thorough, whereas I don't think Canadian regulatory goes into the same level of detail, and I don't think things like NICE do it as well. FDA will request original data. So I have maybe erroneously, a feeling that FDA is doing something really good, and I look to them for meaningful advice. Just because they're the only ones that are actually holding the data, looking at the data in a way that as far as I know, I don't think anybody else does.
And maybe that's what's going on here. It would, like, let's take the stroke or thrombotic event issues. It's almost as if the FDA was saying without saying that they didn't believe the MACE result, that there were strokes that were being missed, or there were MIs that were being missed in this analysis, and that if the proper queries had been done, those numbers would have changed, and that would have changed the MACE outcome. But they didn't say that, and yet they presented that example of how many stroke patients they identified, or at least patients who had stroke mentioned, in their analyses. So it's almost like there's a backstory we're not getting, and for many reasons, neither side maybe wants to tell that story.
Yeah, quite possible. But most of us did have the same perception that Manish mentioned. So, I think there's a question from Dr. Burns. What about PROs, patient-reported outcomes and quality of life measures? Do these agents make patients feel better compared to ESAs?
Roxadustat in their NDD trials showed a statistically significant increase in fatigue, I believe. But the increase was like 1.2 points on a 100-point scale. So statistically significant. Clinically, that would be considered irrelevant. Further supporting the data that really came out of TREAT, where the increase in fatigue, or improvements in fatigue score were were pretty low. It was, and the placebo, that was a double-blind study, so it had an advantage of being double-blind. These were not double-blind. So in treatment of anemia with darbepoetin led to 51% of the patients having a 3 or more point increase in fatigue score, which is minimally considered clinically significant. But 46% of the placebo group did too, meaning only 1 in 20 people at best was having a true improvement. And I would argue that in a blinded study like TREAT, looking at hemoglobin, that could just be unblinding error, that somebody knew their hemoglobin went higher and kind of felt they should feel better, or vice versa. So I don't think that there is really no good data that changing these hemoglobins from averages around 9.5 to higher improves people. I do think, and all of us have these anecdotes, people in the 8s go into the 10s, they feel better, but they're not the people getting into these trials overwhelmingly. They won't get a PRO. They won't get a PRO approval, that's for sure.
Yeah. So it's 9 o'clock, and I would like to thank Professor Coyne again for sharing his wisdom and deep analysis of the data. Hopefully we'll see him virtually next week at Kidney Week. And again, as I mentioned, the